Good morning, everyone. Good morning, everyone. It's lovely to see everybody today. I am Representative Dathan. I represent the 142nd District in the legislature, which is Norwalk and New Canaan. And I am pleased to call the meeting of the Community Hospice Ombudsman Work Group together. I'd like to see if Representative Comey, who's on this call, just lost her. Oh, is she here? I think we lost her for a second. I'll give her a minute, but I'd like to give her an opportunity to say some words. Also, Kathleen Mccarty, who represents, is also representative in the, oh, here comes Representative Comey. Who also is a representative in the legislature, would love to be able to be part of the work group, but she couldn't make it today. So we are hoping that we can, she'll be able to make the next meeting. Representative Comey, would you like to say a few words?
Good morning, everybody. It's good to see everyone. I'm looking forward to getting together this morning, and we will, I will have to leave a few minutes before 11 for another meeting, but thank you.
Great, thank you. I envision this meeting is going to be a little shorter today than the full session due to some health issues and a few other people who've not been able to make the meeting today. And so we have an opportunity, if we decide we could try to meet again next week, or just have our October meeting and maybe go into a little bit more details on the pros and cons if we run out of time today. Hopefully that works with everybody, but let's see where we get to in the coming minutes. We do have a few new faces on the call today, and I'm just going to give people an opportunity to say a few words. I know Julie Robinson, you are new to the group. Would you please introduce yourself? I think you're muted still. Can you check your volume?
Without the headphones, is that better? Is that working? Okay, yeah. Yeah, I'm Julie Robinson. I'm a professor in the Center on Aging at UConn Health. And my colleague Deb Mcnall is with us too. Her looks like her camera's off, but I see.
Really?
Yeah.
Oh yeah, look at I'm black. Oh, wait. There we go. Hi everyone, Deb Mcnall. I work with Dr. Robinson at UConn Center on Aging. Familiar faces. Hi everyone.
Wonderful. Thank you for making the time to be here today. This is really important. Thank you so much. Let's see. I'm trying to go through the names and make sure if you weren't here last time. And apologies, Melissa Morton. Were you here last time? Just looking through my list.
Hi, yes, Melissa Morton from Office of Policy and Management. I was on last time.
Oh, okay. Apologies.
No, that's fine.
Struggling with a little bit of a migraine this morning, so I'm kind of struggling here, so apologies. And I think that's everybody else seems to have been here last time, so it's wonderful to see everybody again. Actually, Josh Flores, were you here last time? I'm just looking at my list. If you want to introduce yourself. Joshua Flores?
Sorry about that. I'm on two Zooms at the same time. Joshua Beckett Flores, Policy for House Democrats.
Oh, I'm sorry. Thank you so much. Great. I think we have done a lot of the introductions, and I'd really like just to kind of jump in and talk about the review of the last meeting on the 26th and the summary. Does anybody have any comments or questions or anything they'd like to add to the record?
Representative Dathan?
Yes.
It's Tracy Wodash.
Yes, thank you.
Good morning, everyone. Just a reminder, Tracy Wodach from the Connecticut Association for Healthcare at Home. Many of our members are both the home health and hospice providers within Connecticut. I followed up with Department of Public Health asking about the complaints that have come through and trying to get any kind of trending, but I haven't heard back yet.
Okay, great. Well, hopefully we'll have some of that information for the next meeting, but I appreciate you following up with that. My constituent, Diane Lauricella, emailed me and her schedule changed for this morning, so she cannot make today's meeting. What she did want me to do is she wanted to clarify one of her statements that she made at the beginning of the meeting. And she understands it's not a verbatim account of the discussion, but she just wanted to add some additional context to what she had to say. And I'm just going to read it for the record. Mrs. Lauricella stated that Home Hospice Agency misrepresented the terms of leaving the program to the patient and her family and did not properly and effectively offer counsel to the family when the problems occurred about hospice methods. The Home Hospice Agency escalated the tension and anger of the patient's family and acted if no one could stop them. There did not appear to be any neutral party that the patients, that could press the pause button to sort out the growing problems. And the agency in question did not offer information about outside agencies like DSS to assist or, if needed, perform an investigation. I have encountered others who had similar experience during their home hospice process. So she just wanted to clarify the record on that. And she has also sent a list of some pros and cons that she would like to discuss. And I'm hoping that we can add that to the next agenda of our next meeting, either next month, or if we do want to have an interim meeting between now and then to that meeting. So seeing that there's no other discussion from the last meeting, I think it would be good if we could go through and go through the data sharing and talk about some of the things that we were able to find from the last meeting. Thank you, Tracy, for your comments, and hopefully we will get some answers and be able to look at that. Mairead, I was hoping that maybe if you could spend a few minutes kicking this discussion off with the sort of complaint process that is in place right now within your organization, so that folks kind of get an understanding. Thank you.
Sure. So good morning, I'm Mairead Painter. I'm the State Long-Term Care Ombudsman. And our office for individuals who are new to the group represents the rights of residents in long-term care communities. So that's nursing homes, residential care homes, and assisted living. And we take complaints from residents, family members, friends, sometimes individuals who are visiting the community or individuals who may be providing a service within the community. So it could be someone in providing hospice services that might see something and call in a complaint to us. The role of our program is to work directly for the resident and at their direction. So if a complaint is called in, we then go and first they would contact the regional ombudsman, and the regional ombudsman will reach out to whoever's filing the complaint. Again, many times that's not the individual resident. Once we receive the complaint, the regional ombudsman goes out and does an in-person visit with the resident to determine whether or not the resident wants that complaint to move forward. It's important that people understand that anyone who's a representative of my office is not a mandated reporter. So residents and family members, individuals can speak to us in a private way, and then we help facilitate a resolution for them. Many times it's us educating them on how to self-advocate. Sometimes they do want the assistance of the regional ombudsman to move things forward and to facilitate a resolution with the long-term care community. Or it could be a complaint about maybe a state agency. Maybe it's related to their approval of their Medicaid at DSS. It could have to do with accessing community options. So they would facilitate whatever was necessary for the person to find satisfaction. If when they go to meet with the resident isn't able to verbalize or tell us that they want us to move forward with the complaint, then they would contact the responsible party if they were able to find that out in a way that didn't divulge any confidential information. So if the person doesn't want, if the complainant said that they didn't want the building to know about the complaint or the agency or the program, we would need to go back to the complainant and say that the resident wasn't able to give consent, and could they give us the information for the resident representative, or we wouldn't be able to move forward if they wanted to keep it confidential. But we would always link them up to other resources like the Department of Social Services or the Department of Public Health, FLIS, which is the facility licensing component of DPH, and their complaint investigation. People always, you can do both. And sometimes there's several of us participating in a case in different ways. If a resident does give us permission to move forward, the regional ombudsman would meet with them, meet with the facility, and we really try to negotiate sort of terms that are satisfactory to the resident, which is different than the Department of Public Health, who's looking at licensure requirements and meeting that threshold. And that's where the difference is. If it's a family member or a resident representative, we look to make sure that they're working in the best interest of the individual, as well as if it comes in from an agency or a service. And so many times it's us working in a group. And then sometimes the resident just wants information. Sometimes it's just information and consultation. And we work with them to make sure that they're fully informed, they understand their rights, and that they can move forward as they see most appropriate. So thank you, Representative.
Thank you so much. Really useful. And I think what we'll do is we'll make sure that we kind of circulate that to the group to make sure that we, everyone's kind of familiar about how it works in other agencies. I think this is probably a good point to call in Julie and Deb, who have been kind enough to join us today. We've been trying to understand really about the number of complaints and what sort of data we have in the state. And I know that UConn has been doing, the Center of Aging has been doing some work in that. So I'm going to turn it over to you all. And if you would like to, I don't know if you want to share your screen and show us what you kind of talked about with the group. That would be wonderful. Thank you.
All right. Is that visible okay to everybody? All right, fantastic. So I'm just going to start out by saying the data that we have analyzed is only administrative claims data. We don't have any data from residents or any data on complaints. So we can't really help you with that piece of it, but this may just set the stage a little bit just around utilization for Connecticut's Medicare and Medicaid populations. A number of years ago, UConn collaborated with Westat, Yale, and the Department of Social Services to look at Medicaid participants' hospice claims data. And we constructed a cohort of people who had died, decedents, using data from 2015 and 2016 Medicaid and Medicare claims. The data were for dually eligible Connecticut residents as well as Medicaid-only residents who had at least 1 month of Medicaid eligibility and a Connecticut zip code at the time of death. And we included people who had at least 12 months of either Medicare or Medicaid eligibility prior to death. So essentially, this is a data set of people who died during those 2 years who had been eligible for Medicaid or Medicare during the year before they died. And we looked at the two populations separately. So the dually eligible participants, those are people with both Medicaid and Medicare. And there were more of those. And then the Medicaid only participants. So we had about 3,000 of those, about 12,000 of the dually eligible participants. And the groups are pretty different. I'm just going to go to the note at the bottom first. So this data includes all causes of deaths and all diagnoses. It's everybody who died. And the causes of death are very different for the two groups, primarily due to the age differences between the dually eligible versus the Medicaid only. So anybody who's over 65 is most likely also eligible for Medicare. So we would expect hospice utilization to be different for people who died who are younger than 65 versus the people who are over 65. So looking at the dually eligible participants, 44% of that group, which is about 5,000 people, did have a hospice claim in the year before they died. On average, they used 50 days of hospice, and the mean age was 85. And then in the Medicaid only group, only 18% had a hospice claim, and they used it on average 26 days, and the mean age is 59 years. So you can see differences both in the percentage of each group that used hospice as well as the length of time that people used hospice in those two groups. We also looked at a little bit more closely at the length of enrollment. So how many people were just enrolled for less than a week versus people who were enrolled more than 180 days, which is that typical 6-month time frame for hospice. And then the group of people that were in between and sort of the more typical frame. So for the, we didn't see huge differences between the two groups, but you can see here that about a third of the dually eligible people had fewer than 7 days, a little more, 41% in the Medicaid only group had fewer than 7 days. And then about half in the dually eligible group had that between 7 days and 6 months use, and a little bit less than half in the Medicaid only group. And so we do have some ongoing work. Right now, we are analyzing additional claims going through 2020. Like I said before, we haven't done any work and we don't have any data for participant experiences related to hospice or any data on complaints. This time we are restricting the sample to those who've died who have the most common diagnoses that would trigger use of hospice, trying to compare, create more comparable Medicaid only versus dually eligible groups so that we can really see if that, is the difference. But the differences that we see are those driven by access to insurance, or is it driven by what the person's, medical conditions are. We're continuing to look at utilization patterns with additional focus, especially on differences by race and ethnicity. And the analyses are ongoing as of this point. So that is pretty much all we've got.
Great. Thank you so much. That's really, thank you, Deb, for coming in and presenting that. I know it is interesting to see the sort of size of the population, and I would envision that, the complaints would only be hopefully a small fraction of that. But this is why this work group's meeting, and this is what we're investigating if we need to do this. So that's really helpful. Does anyone in the group have any questions or comments or thoughts for Dr. Robinson?
I have a question, please. Actually,
yes, please go ahead.
Teresa Bachhuber, Seasons Hospice and Palliative Care. Thank you for that great presentation, Julie. As you move forward, what diagnoses are you going to be looking at? You said most common diagnoses. Which ones will you be looking at?
Yep, so it's a number of cancer diagnoses, dementia or Alzheimer's disease. Deb, help me out with the other ones: heart disease, pulmonary, and I believe there is stroke. One or two others. We could send you the specific list if you'd like, but those are the ones.
I'm not sure I could do it off the top of my head. You did better than I did, Julie. But we did look at the literature to see what were the most common diagnoses of people with hospice, and that's how we decided on the on who we would include, and we're using their ICD-10 codes associated with their hospice claim to look at that.
Excellent. And this is just Connecticut, correct?
Yes, just Connecticut, and just the either Medicaid only or Medicare plus Medicaid. The data is DSS data that that is matched up with Medicare claims for people on Medicaid.
Beautiful.
So we don't have a Medicare only group.
Excellent. I'm looking forward
What's the
to
rationale for that?
I'm sorry.
What's the rationale for not also looking at the Medicare only cohort?
We don't have that data. We only have data for the Medicaid group because it's through Department of Social Services.
Ah, well, we might be able to help with that. Tracy?
Yeah, thank you. I was going to say that we have all the Medicare claims data through 2019 at this point. But I did have, and I'm happy to present, and it's the same, in the same format, the length of stay, the percentage of decedents who received hospice care, and I can't remember the last one that you did, but it's I can get that data without a problem. I guess my question, Julie, is, and does it make any sense? Because I know we're looking at Connecticut, but the numbers are low, you know, for Medicaid only. Is there any kind of trending that would help if looking at Medicaid countrywide, or, you know, just, or maybe New England? I mean, just to see a little more on the trending, because the numbers are pretty low for Medicaid only. I mean, a lot, especially the population, and Chris and Teresa can certainly speak to the populations they serve, but they tend to serve more the dually eligibles than the straight Medicaid only.
Yeah, I mean, I think looking at either cause of death or diagnosis first is important, because a lot of those may be, you know, deaths that are due to accidents or other things that wouldn't be typical, you know. So I think you need to separate out that group of people that you wouldn't expect or hospice wouldn't be appropriate for, and then see what the percentage is of that other group. So that's what we're in the process of trying to do right now.
Okay. Yeah, especially with just an 18% use of hospice under Medicaid only. I mean, that makes sense to me because it's a much younger population, and I agree the diagnoses or the cause of death could be very different.
Yeah, I think it would be really interesting to look at other states too. I know that Connecticut was one of the later states to add hospice as a service under Medicaid, but that was, I don't remember what year it was. I remember it happening, but it was
Chris, do you know, it was 2008? Was it 2008? Oh,
yeah, 2008, and then 2009 it launched, January.
Yeah.
And I was just wondering, and forgive me if this question isn't appropriate, but the settings, is there a difference in the settings of where these folks are, and have you broken that down?
We have not looked at the settings, but other people have looked at that in the literature, so that it can be important. I mean, I've actually seen that our colleagues at Yale have done some really interesting analyses looking at transitions through settings. So people in hospice and how they move from, you know, hospice at home to hospice in the hospital, and where they are at the time of death. I'm not sure that we have all what we need to do that kind of analysis, but could be a next step.
Yeah, because Rep Jason and I also sit on insurance, so we're also like really stymied by some of the high hospital costs, and also the long-term care insurance. I'm wondering, you know, how that comes into play. Thank you.
And just also the purview of the group. I mean, we're really focusing on the home aspects. So I think that was a great question, Rep. Comey, because, you know, because of what we're trying to figure out here. But that's super helpful.
I can share, if it's helpful, I could share the Yale, what's been published that from Yale, in that I find it really interesting. You may too, about the transitions of care, and of course, you know, quality, you know, I don't have the, I'm speaking more anecdotally. We know that quality, if you're going in and out of the hospital and many transitions of care over 6 months, that's probably not as good of quality of life. So reducing the amount of transitions of care would be really important for quality. So I can share that. It's just interesting. I'm not sure it quite fits with what you're talking about
Yeah.
here, but
Yeah.
I can.
And if I remember correctly, they use 2011 data, so it's not really
not
current.
new.
Very dated. Yeah.
Yeah.
Well, if you could share that with our administrator, that would be wonderful. Heather Ferguson Hall, great email. You could share it with her, and she can disseminate it to the group.
Sure.
Great. Is there any other questions before we move on to Dorian? Oh, there she is. You keep bouncing all over my screen, Dorian. I'm trying to keep up with you. Do you have the ability to share your screen to share with the group what you've sent to Heather?
We cannot hear you. Can you turn your mic on?
There we go. Every meeting, there's always someone that doesn't turn their mic on. So let's see here. I'm having a little challenge with my computer today. So I'm hoping that I'll
Dorian,
be able to.
Would you like me to share my screen and then
that would really be,
I have it open, and
that would be super helpful because I'm having some technical challenges.
Don't worry. We're here for you. Thank you for
it takes a village.
It totally does. Okay, here we go. Can everybody see my screen okay?
Yes.
Oh, wonderful. I'm going to make it a little bigger.
Okay, so annually, the department issues a report to the committees of cognizance related to the protective services for the elderly program. It provides a general overview of what the program does, which provides, response to allegations of maltreatment to persons age 60 or older. The calls come into a centralized hotline here at the department located in our central office. If those cases are accepted for investigation, they are then assigned to regional office social workers in the community. And we sit in most of 10 of the 12 DSS offices, and we make a visit to the individual who's alleged to have been maltreated. Our hope is to interview that elder alone to get a understanding of what their circumstances are. But our purpose really is to, protect the well-being of individuals and to partner with them to resolve any allegations that have been reported. As you can see, we have received over 11,000, almost 12,000 allegations of maltreatment. And just so for a point of clarification, an individual case can have more than one allegation. So, for example, neglect is one of our more common allegations, but an individual could be alleged to have been neglected as well as financially exploited or physically abused. Just so you understand the difference between allegations and cases. As I said, neglect, including self-neglect, is the most common. Women tend to have more cases than men. A lot of that is related to life expectancy. And during this last year, particularly at the beginning of the pandemic, our referrals were down a bit. But we've been on an upward trajectory of referrals year after year since issuing this report. Right now, just to give you an understanding of the staffing that we have about 80 staff that are deployed to address the needs of the program. And as I stated earlier, we have a centralized intake that allows us to take referrals, work days, state of Connecticut work days, Monday through Friday. And then on weekends and after hours, 211 is able to accept reports for us. So folks can make reports of maltreatment there. And we do have workers that provide on call for telephonic triage and support and referral, on highly urgent cases. Others that come into 211 that may not meet that threshold are forwarded to our staff at the intake line to triage and send out to the regions the next business day. So we can go on to the next page. So in looking at our process, we have a lot of partners that we work with when providing this level of support to individuals. So, as you can see, the areas on agencies on aging, our partners in law enforcement, community-based providers, financial institutions. It really takes, a lot of collaboration to provide quality services to folks who are alleged to be maltreated. And many of these entities are key in preventing us from having a client have that need for intervention. So we're very grateful for our community partners that really allow us to have a system to support folks who are at risk of maltreatment. You can go on to the next page. Thank you. You're a good navigator. So, but overall, just to let you know, we talked about the numbers of individuals served. As you can see, due to COVID, there was a bit of a drop in the number served. And we tend to, for this report, actually, the legislation requires that we report on calendar year. But we found that when we jumped around and used like state calendar year, federal calendar, people got really confused with our data. So we really have stuck to doing calendar year as kind of our benchmark for community reporting. But if anyone, is interested, I think you guys understand the whole difference of data and, a federal year and state year. But we find when we report to the public, it gets very confusing when they see one number for 2020 and another number for 2020 and it's state and federal fiscal year. So we stick to calendar year and reporting that just so that you understand how we do our thing. But, demographically, Connecticut, is one of our a state that has a high elder population and, is going to, we're going to see an increase in reports and have seen an increase in reports. And we are on trend this year, likely to match our 2019 numbers of referrals. So the COVID pandemic is not as adversely impacting our referrals as it did in 2020. Go to the next page, thanks. And then we get down to the nitty gritty, which is the data, right? So as you can see, we just like to provide, as again, this page highlights the legislation that mandates this report. And I provide an overview of the complaints, what their disposition is, and whether or not the categories have increased or decreased. As you can see, as I spoke earlier, females outnumber males as far as our referrals are concerned. You can scroll down just a skosh. And then I also find the breakout in age to be, pretty enlightening. I know that I recently did a presentation for folks on the Protective Services Program. And, as we move through our society, as folks live longer, folks are like, age 60, that's so young for protective services for the elderly, right? But Connecticut is unique. We do not have an adult protective services program for folks age 18 to 59, as most other states do. So we begin at 60 with these services. And as you can see that, we serve quite a few people in that age group. There's not, great differentiation. And, Dr. Robeson, you can tell me what's statistically significant. But when you look at the numbers, here, you can see that there's not, great variation based on age band until you start getting into the upper ages. But I remember doing this report and just running these numbers for our own review. We didn't have, individuals over 100 residing in the community, because remember, these are individuals that reside in the community. And so you can see our population numbers are jumping up there, and there are a lot of folks living, often independently, upwards of 100 years old. So, it's a good thing that folks are living longer. It's unfortunate that, sometimes they end up in circumstances where our interventions are needed. But I always like to remark on that. And the last page. All right, so we go into substantiation of maltreatment and, identifying the cases where we've identified whether or not maltreatment is included, it has occurred. We do not count our self-neglect numbers in that. And I'll be honest, I think this is substantiation and not substantiated categories are a challenge for APS programs across the country. And is something that the National Adult Protective Services group, as well as the Administration for Community Living, are interested in looking at. And it's something that we're looking at, kind of ensuring that we are substantiating appropriately in maltreatment cases. And it's something that our focus in our program really is a social support model. And I think that sometimes substantiation can be challenging for us in cases because there's an impact on family relationships, et cetera. But it's definitely something that I think is an area of potential growth with the Protective Services program, just putting it out there. And then on the actual categories of maltreatment, again, you see a decrease in all of these due to the COVID pandemic. But as you can see, the breakout of the cases, there are a lot of allegations related to neglect is our largest category, as you can see, followed by financial exploitation, which again, we partner with the Department of Banking and other entities in addressing and continue to work on, elevating our practice across all of these categories of neglect or maltreatment, as well as with law enforcement. So, we're busy, providing supports to service our clients that are referred, and appreciate our partners out there in the community that make it possible for us to do what we do. Any questions?
Thank you so much. That was really, really helpful. I'm gonna let others ask questions first. Tracy.
Hi, Dorian. It's
Hey,
Tracy
Trace.
Wodach. How are you?
Good to see you.
You too. Thanks so much for this overview. It's really helpful. I guess I'm wondering on the process, and it's a question that I get from a lot of our providers, both home health and hospice.
Mm-hmm.
You had the report of nearly 12,000
Allegations. Yeah.
Allegations coming in, yet just under 8,000 investigated, so 2/3. So how do you review that? How do you determine what to investigate or not? And then what kind of falls into, I'm seeing a lot on the self-neglect. So I guess I have two questions. I'd like to know on both sides how you manage those.
So just a clarification on data, that represents all of the allegations that were investigated. So what that means is that an individual could be referred to the Protective Services program. So that would be one case, right? But they could be alleged to have been physically abused and neglected. So that's the differentiation in the numbers. That information does not reflect cases that were not accepted for investigation. That reflects just the number of individual allegations that we received as opposed to the number of cases.
Okay, so one person could have 3 allegations.
Absolutely.
You're investigating it, but it's one person, so your numbers.
So it's one case, yes.
I get it.
Mm-hmm.
I get it. Thank you.
No
and then
problem.
Self-neglect, can you just expound a little bit on self-neglect and what you're seeing?
So when you look at our statutory language, it really just has the category of neglect, right? But, we really want to break out, is this a circumstance where someone has a caregiver that's been designated to, provide supports to that individual, has kind of placed themselves in a place of being a caregiver for an individual? Or is this an individual that lives on their own, but is struggling to meet their care needs? So, this happens frequently. You have an individual that's responsible for themselves, but, due to whether it's a health issue or a cognitive issue, is unable to do so. And so they may not be able to manage their environment or their physical care needs, activities of daily living, et cetera. That's where we start to kind of, differentiate that, because sometimes there's not someone that's quote unquote in charge or a caregiver, but they're on their own. So, but we want to address those issues, right? We don't want to say, oh, you don't have a caregiver, so we're not going to intervene, because people need help.
Right. So thanks for clarifying that, because it's really important as it applies to hospice and the discussion that we're having. Because when and those that provide hospice that are on the call, you can certainly expound further. But for a case to be taken up for a hospice, there does have to be some family or caregiver support in the situation. So the self-neglect piece is highly improbable for coming to fruition, but the other areas are things that our providers frequently come across in the hospice situation, and things that our providers would be reporting to Dorian's department. So
a great point, Tracy. Thank you for bringing that up.
I think to that point, though, I'm sorry, Lucy, go ahead.
That's okay. Go ahead.
Well, I think to that point, you know, in my experience with the self-neglect is that once you get them in the, you know, once you get the protective elderly services in, then they got into an environment, a hospital environment in the case that I was involved in, where we got them the care that they finally needed. And then they, you know, could be most certainly reflected into whatever care needs they may need regarding hospice care, especially if it's, you know, sort of deficiencies that with, you know, Alzheimer's or things like that would come up.
Absolutely. And our goal in the program, whenever possible, is to help folks be supported in their community, preferably in their home. And so, you know, and we do, as you noted, sometimes we do encounter individuals, and we don't have data on that. We are looking to upgrade our data system. We got some money from the Administration for Community Living to help with that. So, you know, that's like my other job, right? Trying to figure out how we get a new case management system. But you know, to really look at, we do, anecdotally, I can tell you that we have encountered clients that are self-neglecting, and it turns out that they do have some type of terminal diagnosis, whether it's advancing dementia, or if it's, you know, cancer or some other issue that has arisen that has moved them to a place where they're unable to care for themselves, have no caregiver, and then really need to kind of transition to, you know, getting supports that they need. So, you know, these grave issues do come up, you know, and relate to protective services frequently. So thank you for sharing.
Yeah, exactly. And I'm really glad that, you know, impressed to see that, you know, you all are not working in a silo. You are working across various agencies, have various community partners. So that really, really does help. And kind of bringing it to this group, because, you know, this population that you're talking about is a greater population than necessarily comparing Connecticut to other states. Do we have any data to say, based on the total number of people that are being served, whether they're in a Medicare or Medicaid or other type of setting or at home, do we have any sort of metrics to say what, you know, the percentages of complaints are outside of necessarily a hospice situation, but just kind of overall compared to other states, preferably New England states?
So I mean, there may be some data that we'd be able to identify because we all report to the Administration for Community Living. So there may be some areas where things could be compared. We don't necessarily have that data. But, you know, what I can say is that across the country, the design of adult protective services programs is very different. So, you know, our colleagues in other states may be serving people age 18 to 59. We do not. Some states have bifurcated systems where one agency does 18 to 59, another one does age 60 and older. So their databases, what they collect, how they do their business vary significantly. So it is hard to compare apples to oranges, you know, when it comes to national studies for APS. I think there's a little bit more uniformity on the child welfare side. I started off at DCF before coming here 17 years ago. My God. But yeah, the
you were just a 20-year-old at the time.
Yes, I was 12. I was a baby. So, but the reality is it's difficult for us to compare. I mean, you know, if you have a specific question, I certainly can inquire whether or not that data can be secured.
Okay, let me think through that a little bit closer, because I do, you know, I really want to make this sort of data relevant for this group. And what we're hoping to achieve. And, you know, there's always the concerns, it's not the data necessarily we have, it's the data we don't know about, that the cases go unreported, the families that don't, maybe aren't part of this, aren't aware of what the reporting mechanisms in place. And so that's always my concern, is the outstanding population. And sometimes if you have a idea what the percentages are in other states, that might be able to say, are we missing folks? So,
Yeah, I mean, we're definitely missing folks, because maltreatment, whether you're talking, child welfare, domestic violence, interpersonal violence, adult protector, they're all underreported. The one thing I can say is that through the Administration for Community Living, in a partnership with the National Adult Protective Services, we're embarking on a national campaign of awareness of adult protective services, and Connecticut will be participating in that. So, soon we'll be able to have, cool glitzy commercials and cool websites and things that really provide, ample information to folks about what the program is. I think our professional providers that are mandated reporters are pretty aware of what the expectation is. But we are always willing to do, outreach or trainings to folks. And Tracy, you and I have partnered, to do presentations. I've, gone to up at UConn, I've gone to the dental school, like wherever folks need us to, present on the importance of this program, we are willing to do. Because I think if folks don't know that we exist, then they can't make that referral. And sometimes also we can provide information that may mitigate, the need for our intervention. Maybe folks are not aware of the Connecticut Home Care Program, or that there are other community-based providers that can offer case management and support to make it easier for family members to, be a resource for their elders or other folks that may have, health issues and need support. So, again, if you think that would be helpful, glad to do that.
that's great. I do think, maybe you and I can connect offline and have a little bit more in-depth conversation, and seeing what we can do to bring it, again, relevant for this group. I see Mairead has her hand up. I'm going to call on her now.
Thank you for popping around. I just wanted to sort of reiterate what Dorian is saying, that we both report to the Administration on Community Living, and that's where there is a lot of challenge that every state does it differently. And even data collection, when we're doing comparisons across states, even if we're collecting similar things, because we serve different populations in each state in different settings, and we call the settings different things, it's really hard for us to use that data. And Dorian and I have talked about this, and we're both part of the Elder Justice Coalition, looking at how that's set up in every state. I think they're trying to find ways to do it more uniformly, but not quite there yet. I also wanted to highlight, we recognize that there's sort of these pockets of information, and we want to make sure that individuals have access to sort of a place to call. And so we've collaborated through the Elder Justice Coalition with the Attorney General's office, and there's now an Elder Justice hotline, where if an individual calls that, they will get connected to Dorian if it's appropriate. The Department of Banking, Consumer Protections, our office are trying to sort of help people have one number to call and then get connected in the most effective way to whoever can help them.
I think that's great. Somebody actually, I wasn't familiar with the Elder Justice Hotline until more recently, and I think it was this year, and it was really helpful to see that. And I'm pleased to see that it's, it is a phone number with a real person, so that we can really do that, because, we know that there's technology gaps, and particularly, as folks get older, they may not be as tech savvy. So I think it's really important that we have those services out there. I would hope that we make sure that we publish this information, though, particularly, share it with doctors and share it with other providers in the state. I know I sit on the care committee within MAPOC. I think, we want to make sure that, our FQHCs have this information so that they can be sharing it with folks, because it is super important. I'm conscious of the time here. I know we have some folks that need to step off at 11 and want to make sure that we continue this discussion. And I'm feeling that I'd like to follow up on with some other sort of things that we've talked about for the remaining part of the meeting. And I'm hoping if the group agrees that maybe we spend our next meeting in October really going through the sort of pros and cons a little bit more in depth now that we have some more information of the formation of this. And I've got some things in some input so far, but I might be reaching out to some of the members and just trying to make sure that we can kind of streamline that. And then hopefully next meeting, we have a few of our other, everyone can make it, and we'll able to carry on that strong dialogue. Does that work? And so that we'll just spend the rest of the meeting kind of talking about some of the other points that we talked about in the last meeting to follow up on. I'm seeing a couple nods, so I'm hoping that that is the case. So I wanted to call on Jennifer Cavallaro. I know, if you have some information from DCP about the complaint process, that would be really useful.
Yes. Can you hear me okay?
Yes, we can. Thank you. Jennifer, we can hear you well.
Okay.
Go ahead.
Thank you. Yes, I have been in contact with the Department of Consumer Protection, and Wendy is working on getting me some further information. She actually had done a great presentation on their process for another group that I participate in, so I'm hoping that she would be able to share that with us, and also as well provide some data that would support our efforts. So I hope to have that for our next meeting.
Wonderful, wonderful. That's really, that'll be really helpful. And, I'm hoping that we, again, aren't working in silos and really able to work across our agent, our government, so that we know what's going on and we are able to really support our citizens. Thank you so much, Jennifer. Dawn Lambert, do you have anything that you wanted to talk to today about? I know there was a couple things you were talking about last time.
Good morning, Representative Dathan. I did forward the UConn report. UConn is working. I know that they're at the meeting today, and I think I want to pass to them pretty quickly. They are doing ongoing research for us. This has been an area of interest. We're well aware that Connecticut maybe has some areas to improve in with respect to delivery of hospice care or palliative care, and we have some initiatives that we're looking to move forward. Deb or Julie, do you, Representative, may I defer to them to provide?
Yes, they actually did give the presentation update that you passed forward earlier, and it was really useful.
Excellent.
I don't know if they want to add anything else based on Don's comments.
Did you mention the upcoming work with Dr. Richards et al. Or?
No, we didn't. And unfortunately, I do have another meeting that's starting in 1 minute, so I'm going to have to sign off here. But Don, if you want to just mention that related to palliative care anyway at home. So, and thank you again for inviting us. And I apologize to have to leave early.
Okay, well, thank you so much, Dr. Robinson. It's really, really beneficial and been a really good use of my time and others, I'm sure. We will reach out if we do have any other questions, but Dr. Richards is wonderful as well. I work with him in MAPOC, so happy to hear that there's lots of communication. So let's, I know Stephen Hernandez had some things that he was following up on. I don't know if you wanted to report to the group today, Stephen.
Thank you so much. We continue to follow up on that. Michael Werner's on the call with us. So as soon as we have something, we'll send it to you so that you can review it, and then you can let us know whether you want to go to the rest of the group.
Got it. Okay, that's useful.
Thank you.
Okay. as I said, I think, we've had a really good hour-long meeting today so far, just to kind of talk about some of the things. I'd like to open it up to the group before we kind of sign off. If there are any other things that and data that you think that might be missing that we need to be gathering as we evaluate the sort of pros and the cons of this formation. I'd love to open it up to especially people who are in the industry that provide the services, and hear from them as well. So I don't want to continue to keep talking, but if you do have anything to add, please either raise your hand or just unmute yourself, and we can be casual about it. All right. It doesn't sound like we have much to add there. I do have a couple other people who are planning on joining next time that couldn't join today that really wanted to get involved in the sort of pros and the cons conversation. So I think if we park that as the agenda for today and plan on really kind of digging that into the next meeting, I hope that is agreeable for everybody. And I think, we did cover a lot today, and I was really pleased that everyone that was able to join and kind of follow up on some of these things that we've been talking about. Our next meeting is October 28th, same time, 10 o'clock via Zoom. If you, I might be following up with you between in the next week or so about other things that we need to bring to the table to have this discussion. But if you do have any ideas, I would love to hear from you if you want to circulate it to Heather Ferguson Hall as well as myself, and we can make sure that becomes part of the agenda. Does anybody have any comments before I close the meeting today? I don't hear anybody, so I take that there's none. I really appreciate people coming together. I think this was a good use of time to understand what's currently happening, so that we can kind of think about this as we evaluate the sort of pros and cons. Again, if you do have anything that you'd like to add or talk about, you're welcome to give me a call or send me an email and let me know what's going on and what your sort of thoughts are, and if you have any questions or concerns. So with that, I'm going to adjourn the meeting and just say thank you again for your time today, everyone. It's appreciated. Take care. Thank you.